Okay, no problem.
Here we go. I got my PowerPoint loading.
Excellent. Great. So do you want to tell us a little bit about like your job description, what kind of medical doctor you are, what your role is in the gender care team?
Hey, yeah. Um, my name is Rosemary Claire Roden, MD. So I'm an allopathic physician, and I work at Penn State Health Children's Hospital in the Department of Pediatrics Division of Adolescent Medicine. So that means my primary training is as a pediatrician. So I'm a medical doctor, did 3 years of peds residency after my, excuse me, irrelevant, after my medical degree. And then I did another 3 years in a field called adolescent medicine, which most people really haven't heard of. I think of it as medical management of behavioral health conditions. So like a psychiatrist uses psychiatric medications to manage psychiatric conditions. A psychologist uses behavioral health techniques to manage behavioral health problems, but does not prescribe medication typically. And so I operate in this space where I get to be like a third psychiatrist, a third endocrinologist, and a third gynecologist. So it's like medical problems that have a huge emotional component. So I take care of eating disorders, the medical management of eating disorder and malnutrition, a lot of gynecology, like sexual reproductive health, contraception, STDs, normal sexual development, normal puberty, abnormal puberty, and then also gender care.
So tell us about how the gender clinic at Penn State is structured. Like, what's the procedure for kids who are coming in for the first time?
Okay, so we have a gender health clinic. We're like cycling through names all the time, but basically, Penn State Health in the Department of Pediatrics, we will see patients up to age 25. I see patients age 10 and older for medical care. If someone wants to see me, what happens is they call our therapist. That's the first person they call, right? Her name's Amy Kiesling, LCSW. She's amazing. I love her. She has several decades of expertise in behavioral health and specifically in gender care. So she usually does a telephone intake with the patient and or family, depending on age and depending on family structure and all other kinds of stuff, and determines if this is a person who needs to see a therapist before they can see a medical provider, right? So it's someone where there's not a confirmed diagnosis, there's someone at the beginning of their journey, they're a family who just has a billion questions, whatever, versus someone who can go right on ahead to see a physician or should go right on ahead to see a physician. So that might be like someone who just moved to our area, who's had a diagnosis of gender dysphoria for years, but they just came here for college, like that kind of thing. Patients under age 10 are usually seen by pediatric endocrinology if they need a physician at all in the first place. Patients with DSD, so differences of sexual development or intersex conditions, there's a whole bunch of other words you'll hear out there that describe those conditions that are not okay. So I usually go with DSD, are also seen by endocrine, sort of because those are sort of related conditions, but they are not strictly speaking gender dysphoria, but also require their own specific management. And anyone requiring pubertal suppression will see endocrine. So I see people who are having problems with their periods, both gender related and not, right? People with a contraceptive need, and people with a need for gender affirming hormonal care who have already completed puberty one time.
Okay. Cool. So tell me a little bit about, so you don't prescribe puberty blockers, that's usually done by the pediatric endocrinologists?
Yeah, and that's done for a wide variety of reasons, mostly because I don't have a ton of training in it. I mean, like, I have prescribed it before. Most of the time when I've prescribed Lupron before has been in the context of strictly menstrual management. So that would be like oncology patients who will bleed to death from their vaginas if they don't have their periods stopped, that kind of thing. But in the context of like precocious puberty or puberty blocking for gender dysphoria, I don't have the expertise, so I refer to my endocrine colleagues. And insurance companies don't want to pay for it if I write it, frankly. So I send it to them.
So can you speak a little bit about what puberty blocking treatment looks like, when it's indicated, and how it works?
Absolutely. Let me get a slide up for you. So, all right. So let's talk about prepubertal kids. Can I show a slide? All right. Because this is, as you might imagine, something I get a lot of questions about. And I find that there's a lot of misconceptions about what is and what is not appropriate care. Okay, so this is from a lecture that I give learners at Penn State Health, that I'm seeing for any number of reasons. So about pre-pubertal children. So this is people who have not had any pubertal changes at all. So assigned male people who are up to 9 or 10, depending on what their bodies are doing. Assigned female people up to about age 8, what have you. No one is doing anything medical or surgical prior to puberty. For people who do not have DSD, who are sort of standard issue, assigned male or assigned female, no medical or surgical intervention is recommended for several reasons prior to puberty, right? So the way we assess if someone's puberty has started is if they have had certain characteristic changes in the breast or testes, and also if they have certain elevations in hormone markers. So it's not just like, are you having your period or not? In fact, in assigned female people, menarche, which is the beginning of menses, is the last stage of the physical changes of puberty. So if you're getting someone who has a period, the horse is out of the barn. And so we don't do any hormonal or surgical therapy. No one's giving 8-year-olds testosterone. There's many reasons for that, but mostly it has to do with cognitive changes on the brain. That's why no one's doing that. But also, these hormones affect other systems in the body, right? And if I give a 7-year-old estrogen, they will never get taller than they are at age 7. It'll close their growth plates. So we don't do that. And the genitals of 7, 8-year-olds, prepubertal people, there's not a lot of tissue there. There's not much to work with. There's not a child who can truly express what they need out of their body at that point. And the prepubertal tissue textures are very different from the adult tissue textures. So no one does that. So the only thing that we do in prepubertal kids is thorough, complete gender and behavioral health evaluation and support, right? So most of that's going to be supporting the family, supporting the patient, helping them figure out their way in the world. We can start pubertal suppression with gonadotropin-releasing hormone agonists, which is generic name is leuprolide acetate. Brand names include Lupron, or implants, which are Hystrelin or Supprelin. And those can be started at Tanner 2, testes, or breasts. I don't have illustration of this, but that's Tanner 1 means no pubertal changes at all, child breast, child testes, and Tanner 2 means literally any change for puberty at all. For breast, so that would be the development of breast buds, so any tissue that's palpable underneath the areola at all, and testes would be any enlargement or any pigment change to the scrotum. Or if there's an elevation in luteinizing hormone, because that's the other, the first hormone marker that can be measured. So gender affirming hormones, the guidelines are kind of squishy. They all say age 16 or earlier, which is okay, cool. I don't know what that means. Thanks, guys. So I usually don't do much before age 13 or 14. There's several reasons for that. One of them is if you're an assigned female person and you're transitioning to male, right? You probably don't want to finish your puberty at age 12 when most of your peers haven't even started it. You still want to go through puberty with your cohort. And if you're an assigned male person who's transitioning to female, you don't want to wait until age 16 for a wide variety of reasons, one of which is all of your peers have already gone through puberty. But the other one is that endogenous testosterone that's already being produced by the body, if it's not suppressed, will result in a lot of physical changes that can be very challenging to reverse later on, as well as if you're on a puberty blocker, it can have adverse effects on the bones. So you have prepubertal bone development the entire time you're on a blocker. You only accrue bone mineral density until about age 18. So if you're on puberty blocking medication from age 12 or so to age 16 or so, just because that's what we feel like we should do, you will give someone osteoporosis. You'll give someone the bones of a little old 80-year-old when they're 25. So that's harmful. All right, so puberty 1.0, right?
Actually,
So puberty. Yeah.
So you do blockers until someone is about 13, 14 and then switch to gender confirming hormones?
You can do it that way. You absolutely can do it that way. It depends on the human, right? So some people want blockers, some people don't want blockers. Some people come to you and they have already missed the window where blockers might be useful. Some endocrinologists like to start blockers to remove the effect of natal hormones while starting gender affirming hormones, right? So there's many different ways to approach it. In general, patients that I see are not on blockers anymore. Occasionally I'll get people who still have had like one last shot of Lupron, or like still have a Soprelin implant and they need me to take it out. I love taking out Soprelin implants. It's really fun. It's basically the same as taking out an Nexplanon. For those of you who know what an Nexplanon contraceptive implant is, very fun, very satisfying. So puberty 1.0 is what I call natal puberty, right? So that's the puberty that a body undergoes based on the hormones produced from that person's gonads. So testes or ovaries. So a person is eligible for gonadotropin releasing hormone agonist, so Lupron, Soprelin, Hystrulin treatment if, so there's specific criteria. These come from the World Professional Association for Transgender Health, which is the largest organization for evidence-based care of transgender people, and generally is what most insurance companies use to decide what coverage they'll provide. So a mental health provider, look at my mixed up letters there, can confirm that there is a long-lasting, intense pattern of gender dysphoria, which can be suppressed, typically worsened at puberty with other conditions addressed and stable. So what that means, the jargon is insistent, persistent, and consistent, right? So that means that a person is insistent that they have been, that they know their gender. They have been persistent about it, like they haven't stopped. It's always there. They're always telling, they're always either internally having dialogue or having dialogue with other people. So they're persistent. And then they're consistent, like it's not changing. So in the specific diagnostic criteria, you have to have at least 6 months. But classically, like if you have someone who tells you at age 8, I'm actually a little girl, right? And then by the time they get to age 14, if they've been saying, I'm a little girl, I'm a little girl, I'm a little girl the whole time, it's not going to change. Like that's pretty much what's going on. Now the can be suppressed part means they don't have to tell anybody, right? A lot of these psychiatric or psychologic behavioral health parts of our psyche that we're not sure about that cause us distress, we tend to keep it close to our chest. You know, like you don't have to tell everyone everything all the time, but you have to be able to prescribe not prescribe, you have to, as the patient, be able to describe the pattern. Classically, gender dysphoria gets worse at puberty because all of a sudden you're developing these secondary sex characteristics that do not align with your experience to gender. Occasionally you can have this period of time where people will like be like hyper masculine or hyper feminine, like really play up the assigned birth sex for a little while, and then usually it only lasts a little while and then they go right back to being trans. Not that they were ever not trans, but it's this like, oh, I guess I better try, I should try, and then it doesn't work. And then the other conditions addressed and stable, and that's because people with gender dysphoria are perfectly welcome to have depression, anxiety, schizophrenia, eating disorder, whatever, the same as everybody else in the world, right? Because having gender dysphoria is not a disease. So it just means that all of these other conditions, you just have to have a plan. It doesn't mean you can't have them because you're still a human. You just have to have a plan, okay? The adolescent can give informed consent. I find this a little weird. Yes?
That's a good question.
Yeah.
So I know I'm having students read some articles about like desisters and, you know, controversy about puberty blockers. What's
Yes.
your experience with desisters, if you have any?
So, okay. I have a slide about that too. So the nice thing about puberty blockers, right, what they do is they buy you time, okay? So they're reversible. So like, let's say that you have a 10-year-old who has the first signs of breast budding and and they have intense distress, and it's unclear if they have intense distress about their breasts because they are a little boy, or if they have intense fear, distress about their breasts because they have Peter Pan syndrome and they just don't want to grow up, period. And like, growing up is not optional. Like, you're going to have to do it at some point. That's just the way time works, right? So if a person doesn't know what they want to do, you can give them puberty blockers to stop the gonads from exposing the rest of the body to the natal sex hormones, and give that person time to work with their therapist, work with their family, work with their community, reflect intensely. And then I'm not exactly sure what the time limit is because, again, I don't prescribe puberty blockers. they can either stop the blockers and continue with natal puberty. You know, you will have had some adverse bone effects, but like hopefully you'll feel better about yourself as a human. Or you can use gender affirming hormones. I mean, I guess in either case, you're using gender affirming hormones. The question is, do I have to prescribe them, or do they come from your gonads, right? So, okay. About desisters. So I have one patient who quote unquote detransitioned, and what that particular patient is a really lovely human, still my patient. And that particular patient is really great at describing like why they quote unquote detransitioned. That's not the word that that patient uses, but that's the word that other people like to use. It's extremely rare in children. So by the time someone is getting to me for a prescription, their symptoms have been going on for years, and they have to have been seeing a therapist, because I'm not even getting into like the part where like what criteria you have to meet to get prescribed gender affirming hormones. There's some really strict ones there. And I actually don't love prescribing hormones the first time I meet someone. But so the idea of people desisting, I think what usually ends up happening is that their social milieu when they were a child and an adolescent is complex, maybe not that great for a wide variety of reasons. Maybe their mental health care was not that great for a wide variety of reasons. Their other mental health conditions were not adequately addressed, which doesn't mean that their other providers were like bad at their jobs. It means that these are really complicated conditions that exist at the the intersection of social, biological, and psychiatric issues, right? The biopsychosocial model. So does that answer your question?
Yeah, absolutely. And I think it's important to stress that like you're not seeing kids until they've already been given a diagnosis of gender dysphoria.
Yeah, pretty much. Yeah.
Um,
So the other thing to keep in mind is that most of the literature on detransition comes from adults, which are just like such a different population. So, and most of the transition regret literature comes out of adults. So those are people who transition into adulthood, and their regret usually centers around, because I transitioned, I lost my family. Because I transitioned, I lost my job. I missed this life that I had, you know, which in childhood, what we're talking about is what life do you want to have? You know, how do you want to move forward from here? Where if you transition when you're 50, you're doing a lot of looking back at like, I wish I had had this other life, you know?
and
So
when people transition that much later in life after going through puberty, sometimes they're regretful
it's,
about the lack of like complete physical transition, right?
oh yeah, it's just so much more complicated. And to be fair, I'm primarily a pediatrician, right? So I don't see any of those folk. The other thing is there was a paper that came out in Pediatrics, which is the Journal of the American Academy of Pediatrics, came out like, I don't know, past 6 weeks, very recent, that actually the younger someone is when they undergo gender affirming care, the better their mental health outcomes are later in life. The later someone is when they go through gender affirming care. So if they can't access care until they're 18, 19, 20, then they tend to have more mental health complications, including eating disorders, substance use, etc., so depression, whatnot. So it feels really backwards to say we should start early, because we always want to say, well, what if they don't know? What if they change their mind? But starting early doesn't mean giving estrogen to a 7-year-old. Starting early means seeing a therapist.
Awesome, thank you. Sorry for interrupting.
No, it's fine.
I
Let's
just
hear it.
the worsened at puberty thing I think throws off a lot of people because they're like, what if they don't go through puberty? But I think you did a good job of explaining that that's not really what puberty blockers do.
No, you have to, because like I absolutely don't want to give someone a medication they don't need, especially one that has as much risk as leuprolide acetate. So without like having a good reason. And then and also to get puberty blockers, a medical provider of some type has to confirm that there is onset of puberty, right? Like we have to confirm that it's happening and that there are no medical contraindications to blocking puberty. So we talked about adverse effects a little bit. We mostly talked about prepubertal bone mineral density accrual. And we didn't really talk about impaired fertility. So if you block someone's puberty and then they undergo gender affirming hormone therapy, having never completed their natal puberty, there is a very good chance of impaired fertility. So like not being able to have your own biological children. This is complicated. So this is one of the reasons why people do like to maybe wait a little while and wait till someone's older. One of the caveats that I would say though is that the United States has a very weird history with our feelings about other people's fertility, which is beyond the scope of this conversation, frankly. But what it comes down to is there are plenty of other medical conditions where a person may not achieve fertility, right? It's very complicated. We also don't offer, even for those other conditions, insurance coverage for sperm banking or oocyte retrieval or any fertility preservation modalities, right? So yes, it impairs fertility. It's a lot of conversations about what we're going to do about that. But ultimately, like, adults have infertility too. Like, there are plenty of times where people like don't find out they're having fertility troubles until they're like grown up. So like there's a lot of stuff to say there. And then finally, the last point is limited data on brain development. So the data on brain development, because we know that gonadal sex hormones are really important for cognitive development, right? Both estrogen and testosterone, that's part of puberty. The brain development we have on long-term use of leuprolide acetate, excuse me, comes from its use in, I think it's like 7-year-old cisgender white females with precocious puberty. And that's to say that, like, I really don't know how generalizable that is to any other population.
So I guess my next question has to do with the stage after puberty blocking or puberty suppressing. What does gender conforming hormone treatment look like?
Yes. All right. So puberty 2.0, right? This is gender affirming puberty, medically managed gender affirming puberty. So puberty 2.0. Okay. So after GnRH therapy or after natal puberty, gender affirming hormone therapy can start. So the really basic idea, there's a whole lot more to it than this, but the really basic idea is management of testosterone. Testosterone is a very potent sex hormone. So in general, AFAB people may not have enough. Not necessarily. Many AFAB people, which is assigned female at birth, excuse me, feel just fine and don't require testosterone. Like for like the purposes of teaching, let's just say that that's what's going on. AMAB people may feel they have too much. We have to always discuss the goals of transition with a patient before initiation of hormone therapy. Like, where do you have your dysphoria? Where is it? What can we do to alleviate it? Because the goal of gender medicine isn't to, like, I don't know, give someone a body transplant, because I can't do that. No one can do that. It's to help make it feel better to live in the body you have, right? So it's like, okay, for this person, does getting a different haircut and wearing different clothes, is that enough to alleviate the dysphoria? For this other person, is it changing their name? Is that enough to alleviate the dysphoria? If it's not, if your dysphoria, let's say that it's an assigned female person, if their dysphoria is all about their chest and not about their voice, not about their lack of body hair, not about the shape of their hips, that kind of stuff, they may require top surgery, which is breast removal with chest wall recontouring and no hormones, right? So, and that's fine. In the guidelines, that's totally fine. So it depends on where is this person's dysphoria? What do they want to get out of therapy? How are we going to get there? So assigned male at birth people. So we use estrogen. It's not the same as birth control pills. That's what it comes down to. Different estrogen, safer estrogen. And you can use it with or without blockers. So these are not the same as puberty blockers, right? These are testosterone receptor blockers. So it's like, I can give you estrogen, which your body responds to through estrogen receptors, which are present in all human bodies. And then also it suppresses the natal function of testosterone, like the natal production of testosterone. So, but there may still be a good deal of testosterone there while we're working on getting its levels down. So for that, you can use something called an androgen receptor blocker. And androgens are like a class of sex hormones that are associated with male secondary sex characteristics like testosterone, androstenedione, DHEAS, whatever. So the medications that we use for that, typically I use spironolactone, which is actually a blood pressure medicine, but it blocks testosterone receptors. So I use it all the time in my assigned female patients with polycystic ovary syndrome, where their bodies make just a skosh too much testosterone and it gives them acne and body hair, and they love it. They love it because it makes them feel so beautiful. I never give it to my assigned male patients who are cis males because they can't get an erection and they also get boobs and they hate it. So, what do you want to get out of this? If I can't use Spiro for whatever reason, there's other medications that can be used. I don't find them as effective. You can also give oral progestins, which is medroxyprogesterone. And
Is
ultimately,
finasteride a drug for hair loss or used for hair
yeah,
loss?
yeah, it blocks testosterone receptors, right? And hair loss is caused by the effect of testosterone receptors on hair
Right.
follicle. Yeah. Um, a person may ultimately need those puberty blockers, really, to shut down the function of the testes, should they decide to keep their testes into adulthood. I don't usually see those patients because they're a bit outside my age range on the upper level. So, in the initial dosage and how much medication we're giving people, it's variable between guidelines. Like, how often do you give this medication? Which medication should you give? I mean, they're all saying, like, you should give 17 beta estradiol, but like, should it be a pill? Should it be a patch? Should it be a cream? How often? What do you monitor? That kind of stuff. It depends on whose guidelines you read. Adverse effects, mood changes, erectile dysfunction or decreased libido, clot risk, especially in smokers, migraine, weight change, fertility changes, hepatic adenoma, which is a benign liver tumor, which I realize if you're an undergrad sounds like that's not a real thing. All liver tumors are bad, but that means that it's basically just a big space occupying thing that you can kind of just take it out as opposed to something that's going to spread all over your body. And a prolactinoma, which is an endocrine tumor inside the skull that is not a brain tumor, right? Like, it's not brain tissue, it's endocrine hormone producing tissue. So the clot risk, basically, if someone's a smoker, they should, and they're on estrogen, they should take a baby aspirin. The end. Or quit smoking. But like, if every time I told my patients to quit smoking, they were like, okay, good idea, doc, never doing this again, then like, there's a whole field of medicine that wouldn't exist. And that's like, that's not realistic. So we meet someone where they are and they say, try to quit smoking. While you're at it, here's your baby aspirin so you don't die of a blood clot. Cool. You can stop estrogen therapy around age 50, which is like a menopause equivalent. You don't have to. Some people don't even start estrogen therapy for their transition until after age 50. That's, again, an adult medicine problem. And I, as a pediatrician, do not take care of 50-year-olds. So let's say for assigned female people. So there's generally two components: menstrual suppression, masculinizing, right? Getting rid of periods and masculinizing. So there's a lot of, for any human that has a period, right, or any human that doesn't have a period but wish they did, there's a lot of emotions tied up in that function of the body. If you've ever read Are You There, God? It's Me, Margaret. The whole thing is about where's my period, right? So it's just like a huge cultural thing. To say nothing of like mood changes that can come with hormone fluctuations, the distress of seeing blood in the underwear, the distress of breast pain before menses, all these other things, the distress of fertility, right? Yeah, it's all a big deal. So suppression of menses is entirely reversible. Like, the way that you do that is beyond the scope of this lecture. I use these techniques in a wide variety of patients. I don't care if a person has a bleeding disorder, right? And every time they have their period, they have to be hospitalized for a blood transfusion because they will literally bleed to death from their period. They're a swimmer and they have to be in the water all the time. They have intellectual disability and cannot cognitively process their period. And so they have hygiene difficulties or school difficulties. They have seizures with their period, or they like to wear white pants. Really don't care. Periods are dumb, okay? If they go away from a medicine that I give a person and we know why they're gone, it's fine. So we can use, there's a wide variety of medications that we can use. And as a pediatrician, I'm not doing anything irreversible. So like, I'm not a surgeon. I'm not taking out uteruses. I don't know how to do that. Keep your insides on your inside. They're disgusting, right? Okay. In general, whereas for assigned male people, we have a bunch of medications we can do. Like, we can do estrogen, we can do blockers. For assigned female people, in general, we only have testosterone. You can use minoxidil, which is Rogaine, for like facial hair. I'm not sure how well it works. The problem is minoxidil and testosterone are both teratogens, which means they both cause birth defects. So it's not birth control, and it is a teratogen, right? That means it does cause birth defects. So I'm very clear with my patients that if they are using their vaginas for sex, and there's a risk of pregnancy from the sex that they engage in, they do need reliable contraception, even though testosterone makes your periods go away. A suppressed ovary spits out an egg every now and again, right? A stopped clock is right twice a day. So it doesn't, many of my patients don't know how they would feel about an unplanned pregnancy. Many of my patients know exactly how they would feel about an unplanned pregnancy, but none of them want an unplanned pregnancy. So we'll just try to avoid that. So testosterone preparations, injection, gels, patches, and creams. That's a whole bunch of stuff going on there that's beyond the scope of this. Usually I do injections because it's the safest, most well-studied, least expensive, most easily controlled. And you might have to switch around between what forms you're doing. So adverse effects, it's very similar. It's increased risk of clot, increased risk of metabolic syndrome, hair loss, polycythemia, which is too many red blood cells, acne, mood and behavioral changes, including libido, which doesn't mean more libido, it means different libido, right? Like a different experience to that part of life. Weight change, clitoromegaly, which is an enlarging of the clitoris, and vaginal atrophy. It's a little bit like menopause. So for people who use their vaginas for sex, they should know that the vagina can become smaller and drier. For people who don't use their vaginas for sex, it can be itchy. There are interventions that we can offer for your itchy genitals.
So that was a lot of great information. So do you mind just like in a quick summary, can you take me through like what is the process if you as a parent have like a 6, 7, 8-year-old who has a lot of gender dysphoria?
Oh, so the first thing you should do is you should go to the WPATH website. So that's wpath.org, and look for gender affirming behavioral health providers, or not necessarily even gender affirming behavioral health providers, but like therapists who know things about gender and children, right? Every medical provider should be gender affirming. And all that means, and that's not like me being on a soapbox, that's the guidelines from all the powers that be that actually license physicians, right? So the American Psychiatric Association, the American Academy of Pediatrics, I think whatever it is, the internal medicine doctors call their thing, the surgeons, ACOG, so that's American College of Obstetricians and Gynecologists, an endocrine society. They all have consensus statements that gender affirming care, which is just use the name that someone tells you to use the pronouns that someone tells you to use, and treat that person like any other person, right? It costs you nothing. It has a tremendous positive impact on your patient's life. There's a good deal of literature that just using the correct name reduces suicide attempts for teenagers. That's like a no risk, all benefit thing, right? That kind of care should be provided in all environments. But if you have a kid who's like exhibiting signs of gender dysphoria, which is complex, right? So if it's a 7-year-old, you would have to meet 6 out of, I think it's 8 or 10 criteria, and it would have to be persistent for like a year. So that would be like rejecting your name, rejecting your pronouns, preferring the dress and hairstyles of your identified gender, preferring the toys of your identified gender, preferring playmates of your identified gender, repeated statements about your genitals. Like, it's a lot of stuff. It's not just like someone's like, I'm a boy for the next half hour. It's more than that. Then finding a therapist who knows about child development and gender dysphoria. That's where I would start. All right. Anything else I can do for y'all?
No, I think that's it. But thank you so, so much. This was really helpful.
It is my distinct pleasure.